And we're live. Hey, people. Welcome to episode 243 of the Sports Therapy Association podcast. My name is Matt Phillips, creator of RunChatLive.com. And as always, this episode is being recorded live at 8 o'clock on a Tuesday on the Sports Therapy Association YouTube channel. This is the 9th episode of our reflection series, and in it very shortly, I'll be chatting with clinical massage therapist Jessica Yanneman of 𝐸𝐴𝐧 Therapies, who's going to be reflecting on episode 222 of the podcast, which was entitled A Therapist's Guide to Hypermobility, recorded in December 2024 with special guest Bonnie Southgate. Just before we do that, I'd like to thank last week's guest, physiotherapist Emily Sweet, who reflected on episode 229, pregnancy-related back and pelvic pain, that was recorded in February with special guest Michelle Lyons. And as I mentioned last week, Michelle Lyons is going to be one of the speakers at the up-and-coming STA Southwest Conference, which is happening in Exmouth this September the 20th and 21st, which is a Saturday and a Sunday, we're pleased to hear, in collaboration with the ST School and Hands On Hub. Tickets are on sale at the @htschool.co.uk, which the STA are in collaboration with, which is why you've got kind of like artwork basically saying the same thing going around. There is a substantial early bird discount, which is valid until the end of June. And if you are an STA member, then there's a further discount, which is valid until the end of June, which you'll find in the Facebook member page. And if you don't know it, then just contact the normal Matt at the sta.co.uk or admin at the sta.co.uk, or just contact us on social media. We will get that to you. Hopefully, it would be lovely to see some of you there. If you're not in that region around Exeter, then don't worry. What we're trying to do, hopefully, is create a new type of conference which we'll be able to take around the country to you, so you don't have to kind of like spend your hard-earned cash traveling miles, getting accommodation. You can wait for us to come to you, which I think is a decent thing to do. But any questions at all, always Matt at the sta.co.uk, and I shall help you. Right then, very excited about tonight's show. By the way, thank you everybody who is listening to the podcast and downloading it. I mean, the figure that I was not sure how this was going to work, but the downloads and the listening has just shot up wonderfully so, which is amazing because that's everything we want to do. We want to reach everybody and help get the good word of our guests and our clinicians out there, and that's happening. So thank you very much if you are listening and downloading. Thank you to people who join us live as well. Just say hi to a couple of you before we bring up tonight's guest. So Deborah Slurigimus, sorry about the pronunciation, says hi. Hi, Deborah. Thanks for joining us. Cecily Hislop is here saying hello. Hey, Cecily. Imi Tester is in the house. Hey, Imi. Angela Thompson says, evening. I enjoyed the live aspect last week, so back for more. A glutton for punishment. Well, there you go, Angela. Thanks for twice in a row. Thank you very much for joining us. That's great. And Sir Glenn Murphy, MBE. Evening to the best PA around, and hi to all. He's so distinguished, such class. Thank you for joining us, Glenn. Appreciate it. Right then, tonight's show. Let's bring up tonight's guest clinician, reflecting on past episode 222, A Therapist's Guide to Hypermobility. My guest tonight is clinical massage therapist Jessica Yanneman of 𝐸𝐴𝐧 Therapies. Hey, Jessica, how are you?
Hi, Matt. I'm good, thanks. How are you?
I'm very well. I'm just impressed that it was Jessica Yanneman and not Jessica Janneman or another combination. So I'm glad we had that conversation. Well done. And I know that you're a good person because you could have sent me here tonight saying Jessica Yanneman, which would have been
much
I would have
better.
admired you, but in a way not. So thank you so much. Let's start. So people who aren't aware of you, I've seen on social media, you've got your fans in here tonight, and it's lovely to see a lot of support for you in the house. So thank you everybody who has shared and done that, because it is a bit nerve-wracking. It is a nerve-wracking anyway. So I'm glad that you've stepped up. But for people who are not aware of you, could you tell us maybe where you are in the world and what you do work-wise?
Yeah. So I'm in Birmingham. I have a clinic at the bottom of my garden. I'm a clinical massage therapist.
And tell us more about history. How long have you been qualified?
So I originally qualified as a kind of spa massage therapist about 6 years ago, so just before COVID. Mm-hmm. Then COVID hit, and I started to do a bit of thinking, really, and I was puzzled by, as you know, people have talked about on the podcast before, the lack of knowledge and understanding of what's going on in the human body that I needed to have in order to do my job. So I spent a lot of COVID time listening to podcasts, learning. And then when we came out of lockdown, I did my level 3, and then I did an ACMT with the Jing, and now I'm on the BTEC 6. So I've got a year left of that at the Jing Institute in Brighton.
Fantastic. So it's great for people to know. So you've come from an area of the industry where you're not allowed to work with injury, and now you've moved definitely into places where you can work with people who are in injury and pain up to a high level. So that's great. So everyone can know. Wonderful. Right then, let's crack straight into it then. So out of 240 episodes of the Sports Therapy Association podcast, you chose episode 222 to reflect on. A therapist's guide to hypermobility, which, as I said, was recorded with the great Bonnie Southgate in December last year. Jessica Yanneman, why that episode?
Well, I'd seen Bonnie at Therapy Expo and was super excited to find a therapist who was talking about hypermobility. So I have Hypermobility Ehlers-Danlos. At the moment, I'm awaiting testing to see whether I've got another type. And I treat lots of clients who have connective tissue disorders. And the kind of journey for me, getting a diagnosis, went alongside my journey as a therapist. And what I had found in my desperation to find anything to help me, but also my daughter, who has the same condition, was that whenever I was talking to anybody about using massage, I was getting a kind of negative feedback that it's passive, so it's not going to help. We need to be active if we've got loose joints. That we're changing structures. There's a risk of throwing things out. And that was kind of happening within the people I was talking to within the kind of bodywork community, but also the medical community. And I was upset by it, partly because I really felt that it could make a difference. And so finding Bonnie and seeing Bonnie speak at Therapy Expo and then the podcast really made me feel that there was some validation there, both for me as somebody living with a condition and for my clients. And therefore a kind of hope, because it would mean that through listening to Bonnie, other therapists would come to realise that it is a really, really helpful modality to have, and not necessarily something to be scared of.
So that's, I mean, I'm so happy that you stepped up to reflect, because it's going to be so informative and so empowering for listeners, because not only you reflect on something you found useful for your trade, but also it's something which obviously affects you personally and your daughter. So you've got firsthand experience of dealing with some of the issues and the barriers which Bonnie talks about on the episode. So thank you so much for coming in and talking about this. Really appreciate it. So Bonnie, we should mention probably as well, people who aren't aware of Bonnie Southgate, Bonnie herself has got hypermobility type EDS, so abbreviated HEDS. And she talked about how she had problems of, her background was ballet, and she was having all these injuries and conditions, and she never thought she had anything wrong with her, because a lot of people around her kind of did, but a lot of people didn't. And then she wasn't diagnosed until she started doing the research herself. Maybe if we could, it was a similar story for you then, wasn't it? Because, I mean, I should also point out that, and this only clicked recently, that in the episode with Bonnie, you were sharing your own experience where you went undiagnosed for how many years did you say?
40 years.
Okay, so yeah, the floor is yours. 40 years sounds horrid. How did that happen?
The really strange thing about it is I didn't get the diagnosis, or didn't even think about getting a diagnosis until my daughter started to suffer. Mm-hmm. So she's now nearly 16. I have asked her whether it's okay for me to share her story, and she's really happy for me to.
Thank you, daughter. Thank you. What's her name?
Evie.
Thanks, Evie. Thank you.
She'll be delighted. Famous. So Evie's nearly 16, but during COVID, obviously we weren't moving in the same way. She'd been a really active circus performer, did lots of aerial work, and we weren't moving in the same way. And hormones were changing, and all of a sudden things started to dislocate within her body, which was obviously, as a parent, terrifying. And we couldn't really access medical services in the same way. And we had a really, really awful time of it, and multiple thumbs, shoulders, knees, jaw, hips, everything. And nobody quite knew what to do, how to manage it, what it was. And there was, we were taken away into a side room to be spoken to about whether anything was going on at home. There were conversations. There was a doctor's letter where he wrote that she was being manipulative. There was an awful lot of gaslighting, disbelief. And so I hit Google and started to do my research, because I knew that something wasn't right. And so eventually we got to a clinical geneticist, and they asked the questions, of course, around me. And I mean, it's classic. I had all the party tricks as a kid, fainted a lot as a teenager. They looked at my flexibility now, and I hit various points on the Basin score. But the thing that became key was when I was 25, both my retinas detached. And so I'm partially sighted in one eye, but for a while I was completely blind. And at that point, their ears pricked up. So it was interesting, because they were saying that Evie's hypermobility was on within a normal spectrum, but there was something about the fact that both of my retinas are detached for no apparent reason that then meant they looked deeper. And it was at that point that, that we got the diagnosis. So that was about a year ago.
So it's kind of shocking in the sense that it sounds like you were mismanaged for so long and the right questions weren't asked at all. And so you had to go private in the end.
We did. I suppose about 3 years ago, because we were getting nowhere at all. And they just kept saying, this is the normal range of hypermobility. She'll outgrow it. It's the hormones. She's a girl.
You were given that line where you she'll outgrow it.
Yeah. She'll
Bonnie
outgrow
mentioned
it.
that. Oh.
Yeah. She'll outgrow it. You need to stop doing your party tricks, is what they kept saying. And actually, the irony of the thing was that when she was doing the circus stuff, which they deemed the party tricks, that kept her strong. So it was at the point that stopped that things started to fall apart.
Of course.
So we did go private, which didn't sit well with me politically in any which way. We had one appointment, and she was given a diagnosis of hypermobility spectrum disorder at that point. But even that, then we came back, and I think it's important to say I have a huge amount of respect for the NHS, and my husband's a nurse, and I understand the time constraints and all of the rest of it. But even when we came back with that diagnosis, it was, well, there's nothing we could do. And in fact, an OT who we see said to me a couple of weeks ago, we hate it when anybody comes in with an Ehlers-Danlos diagnosis, because there's nothing we can do. And so I suppose, again, that is why Bonnie's episode is so important to me, because there is a lot that we can do. And as massage therapists, particularly, that time we have with our clients to talk and listen, hear their stories, the hands-on work, the aftercare, there is a huge amount we can do. The advocating for them, the writing to the doctors, the helping to signpost. There's a huge amount we can do. So to say there is nothing we can do makes me furious.
Yeah, it's that double-edged sword I get from doing these podcasts, because I hear your story and it hurts so much inside. I hate it. Makes me want to kind of stop the planet and get off. But then it's the idea of the podcast is it gives me joy in the sense that hopefully, we can put this information out there and help empower our audience who, as soft tissue therapists, who probably see a lot of population who are suffering and they want to relax. They need an hour off the discomfort, and they're going to come for what they think is just a massage, just to get away and feel good. And they know the massage can reduce the pain, even if it's only temporary. We can do so much more, can't we, if we ask these right questions and help prevent. I mean, with Bonnie, we were talking about an average misdiagnosis or lack of diagnosis for 10 years. And then you're kind of like, yeah, hold my drink, try 40, you know, which is like, if that doesn't send the message through, and if at some point, yeah, and I love the way you defend the NHS, and we understand, and it's a societal issue like so many other topics we've talked about, but we can make such a difference as soft tissue therapists to get that conversation going, to empower our clients and patients to go back and say, hold on, I'm not happy about that. Whether it's somebody who's been told, oh yeah, heavy menstruation is normal, just go on the pill, or somebody who's been told, whatever it is, it's a party trick, just grow out of it, stop doing this ridiculous activity, all of this stuff. If we can say to our clients and patients, you know what, no, this is not on, go back, be strong to yourself, you listen to yourself, you know this isn't right, go back. And that's unfortunately, that's what's got to be. They go back to the GP who's doing as well as they can, whatever, and say, no, hold on, I've been told by somebody, what about this? What about this? What about this? Keep going. And life-changing, couldn't it? For everyone and everyone involved.
Absolutely. And I think sometimes it's it's exhausting, isn't it? If you're fighting for a diagnosis of something and you've been around so many people or you don't know what's going on, sometimes actually the thing we can do is know about some of the resources, or say, do you know what? I'll go and have a look for you and come back. And then I can give you, there's a wonderful toolkit on the EDS UK website that you can take to a GP, and it helps you have that conversation. So just knowing things like that then you can say to somebody here that, you do that job for them, and it just takes away a little bit of the stress of the whole thing.
Definitely. For listeners who hopefully now thinking, right, I want to do something, but I know nothing about EDS. What the hell is it? I'm definitely never going to say it. You can stick with EDS. Ehlers-Danlos is like a horrible term to try and... You can't fake it till you make it with that, because it will come out 101 million ways. But that's why it's EDS. But in simple language, can you give us as far as we know, what causes it, if some particular populations are more susceptible to it? And then later on, what are some of the symptoms or questions we should be asking to help identify it?
So EDS is a group of connective tissue disorders. So there are 14 of them. We think one of them hasn't been identified. So there's 13 identifiable ones. And they all have very different characteristics. The kind of headline characteristic is the joint hypermobility and pain. But actually, the important thing about it is it's systemic. So it isn't just the joints. Obviously, your connective tissue runs right through everything, which is why my retinas came off. I've got a leaky heart. When I had my son, I went into labour very early because of the connective tissue. So EDS is a group of disorders. Hypermobility EDS, HEDS, HEDS, is the most prevalent one, I think. And doesn't have any genetic testing yet, whereas the others do. And so part of the reason it is difficult to diagnose is we obviously don't have that testing yet. And so the diagnostic criteria have changed. So what you find is sometimes people have a slightly older sounding name for the disorder that they come with. So things like joint hypermobility syndrome. Sometimes people have benign joint hypermobility syndrome, because these criteria change all the time, and indeed they're due to change again. And with that should come easier, better communication with medical professionals about how to diagnose these disorders. And what you also come across is hypermobility spectrum disorder, which is no less of a disorder than HEDS, but sometimes is played as that. And what tends to happen is if you are presenting with some of the symptoms, particularly these kind of jointy symptoms, that cannot be diagnosed as HEDS or one of the other EDSs, you get a diagnosis of HSD. And again, once the diagnostic criteria change, some of those boundaries might change, and people become their diagnosis changes, and that is also problematic because what we've got sitting about are lots of different names for sometimes the same thing, which further confuses an already slightly confused picture. And I think you asked about symptoms.
Actually, before we do that, yeah, because I mean, you've already reminded me. So I think I'm just trying to think. There's lots of. I think the names themselves can scare therapists. What we're saying here is massage therapist level 3, okay, can play just as important a role in the future of this person as a consultant, because you're probably going to be in a better position to ask the question to this person who trusts you, someone who takes their clothes off in front of you and is happy for you to put your hands on you. They're going to be, if you ask them the questions, they'll answer to you because they trust you. So, but you've got to ask the questions. So it doesn't matter if you don't understand the names and the fact there's like 13, 14 different types. But I think one of the things that Bonnie summed up and you've reminded me of is that if to start off, we don't think that hypermobility is a diagnosis, that hypermobility is what, as Bonnie says, an umbrella term. And we've got to realize as therapists that there's hypermobility, which could be applied to a client who's is a great ballerina, martial artist or something, and they don't suffer from any of these other disorders. In fact, they don't suffer from any injuries more than somebody who hasn't got that range of movement. But then within that population, there's another population who have, with further investigation, got other symptoms, which they might not even realize are connected with that hypermobility, which we need to ask them about. And they need to be separated from this other population because they've got systemic, sometimes even life-threatening things going on. So what are some of those symptoms where we've got an athlete or anybody who's come in and we notice that they've said to us, yeah, I've got a huge range of movement, and we might even have put them through some range tests and gone, Jesus, what's happening here? What are some other things we should be asking or looking for which would help us realize this person needs to be referred potentially to someone else?
Things like gastric symptoms. Very often you see kind of gastric IBS type things, even things like heartburn, all sorts of things to do with blood pressure. You know, do you get dizzy when you stand up, you turn over suddenly, headaches, brain fog, bruising easily. I mean, it just threads through absolutely everything. Things to do with thinness of your skin, do you bleed easily, stretchiness of your skin, neurodiversity, that's another thing, mental health, sleep. I mean, it goes on and on, but really some of these things can really help you start to build a picture of what people thought were random things that they had in their profile. When you look at them together, can build a real picture.
So it is recognizing the appearance of these symptoms together. So if they're saying they do actually, if you just, even if you don't normally have on your medical PAR-Q, do you suffer from any gastric problems or stomach problems? It's something that people should start introducing in their just consultation anyway. I mean, you could have it just as a yes/no answer to get the conversation started, but it's that you said, and then along with that, any respiratory issues which might be associated as well, skin issues,
allergies,
yeah,
big one.
So there's loads of conversations which aren't that even taboo. Like, it's not like you're trying to skirt around a weird question which you might feel uncomfortable with. It's simple questions, but you just got to ask them and then have the confidence to think, well, hold on, we've got this and this and this going on. And then what do you wish someone had said to you? Imagine you'd gone for massage back in the day and they'd asked this and you'd gone, yes, yes, yes. What should they have then said you to? Who should they have sent you to? What do you think? What do you wish had happened?
I think maybe rather than sending me to a doctor straight away, I think signposting me to, if it had existed, something like the EDS Society.
Okay.
I think that, I feel recently, I'd say like 50% of my clients come to see me because they have a systemic hypermobility connective tissue disorder. But I'm seeing more and more people who come for something completely different, an Achilles tendinopathy or whatever. And then say when you're doing your questioning, oh, well, somebody once said that I'm double jointed, or somebody said that I overextend my knee, something like that, and it almost comes as a badge of honour, like, oh, look at me, I'm really bendy. And in those instances, I obviously ask all the other questions around it, and I start to piece it together in my head. But I am very aware that if you look up EDS, it is a huge spectrum, and the things that you are going to see can vary massively, and it can be quite a terrifying thing to be confronted with. So I think, having a particular resource like that GP toolkit, or, a website that covers some of these symptoms, but that isn't Instagram, that is going to show you a whole lot of stuff that isn't necessarily helpful. Something like that. So, because there are also all manner of things that, like I said, when I learned that that's what I had, I started to go, oh, gosh, yeah, that's why I fainted all of those times when I was a teenager, and that's why I had those awful migraines. I probably wouldn't think to even bring them up at a doctor until I knew a little bit more. So I think some of that kind of signposting as a step before you even get to the GP might be a helpful thing.
That's a great answer. It's really good, because thanks to organizations like you've mentioned, we'll put links to these in the show notes, then you can probably get some more, because GPs are masters at or have such a little bit of knowledge of everything, but they're not specialists in this, which is one of the problems. And they get 10, 15 minutes and they're probably tired. Whereas if you go to one of these organizations, you're going to meet someone who's going to be loads of empathy and understanding. Chances are, although it's not necessary, they will have maybe gone through what you are going through, and that'll add to what they can offer you. So great idea. I mean, and really, as we see on the podcast, there's so many, once you start thinking of this, and women's health issues or male health issues, rheumatoid arthritis, once you start thinking of all of these systemic things which are here in society and we could help with, then you should be asking all these questions anyway, because you'll probably, just to cover all your bases, all of these things need to be asked. So very powerful. People in the audience, you've gone very quiet. Is that because you're writing things down on your notebook? I can't believe Imi and Cecily haven't jumped in and said anything yet, but I'd be interested to hear whether you have come across anybody or treated anybody. What do you know what the incidence is like? What percentage of the population are likely to be suffering from some kind of hereditary connective tissue disorder? Or
I don't know. But what I do know is that they think that HEDS particularly is more prevalent than we realise, because obviously of the diagnostic issue.
And it's women more than men generally, or
it is women more than men, because of the hormonal component, I think. But there certainly are men out there who struggle with it.
Fantastic. Okay. The skin conversation, I think, is an important one that Bonnie highlights, because if there's any word that comes after hypermobility, it's probably stretchy skin, and that's, and because that's a lot of the time that can be one of the symptoms. But I think Bonnie spent some time kind of explaining that it's not necessarily what we envisage with like skin coming out a long way. It's kind of more, it comes from all over the place rather than just localized. But is that something you said that you experienced? How would you describe it? What should people be looking for? And
I think that's another thing that you can spot quite easily, actually, is not so much the stretch. I'm now stretching my hand. And it is exactly like Bonnie says, it stretches from different angles rather than in one kind of line. But the other thing is that you tend to have this kind of scarring. I don't know if I can show you mine.
If you listen to the podcast, this is where you pause and you go to YouTube. That's fine. It's good to go to YouTube.
But scars that don't heal well, or heal. Mine are very wide. And so sometimes you can notice that on people, or like when you've had an insect bite and you've picked at it and then it doesn't tend to scar over properly. So things like that you can notice on people's bodies. The skin feels different, moves differently under your hands when you're working. And that is a really, I think Bonnie says it, and it's obviously, because Bonnie said it absolutely right, that you either feel a kind of doughy, skin feels doughy, the fascia feels kind of squidgy, or there's a tightness and everything's absolutely locked down, and you tend to find it's one thing or the other. But I certainly don't feel, I think people are scared of the skin thing, that they're going to rip your skin open or something. And I really don't think there's any need to feel that. If you've got somebody with a vascular EDS, that's a slightly different situation. But I would say, as somebody with EDS having treatments, the nicest thing is when somebody gives you a kind of firm pressure, because you feel safe. If somebody feels uncertain and is trying not to to give you much kind of pressure on your skin, you can feel that uncertainty, and that's troubling, and it doesn't make for a calming of the nervous system.
Yeah, well put. So yeah, and I think, as Bonnie pointed out, as well as, you might pick up on this, the skin, the different sensation, especially if your hands on, you're going to be kind of like be able to test for that. But then it's, as Bonnie kind of reiterated, it's asking the other questions as well, isn't it? It's not just looking for the skin and being able to touch the floor easily. It's the gastric and the maybe respiratory issues and all of that kind of stuff as well, to get a better picture. Right, we've stimulated a little bit of questions here. Let's have a look. Cecily's apologised for being quiet tonight. Okay, you led off, Cecily. She says, sorry, busy listening, but I do have a friend who has a version of EDS and has to permanently wear a body and face brace. Potentially they may have to their jaw wired together to stop dislocations. Familiar with that? Everybody's different.
Yeah, so my daughter had a spell. We had we had a few weeks in hospital. She had a dislocated jaw that she struggled with for years, actually, but it got to the point, and this is another thing with the dislocations, that recurrent dislocations, obviously everything gets laxer and laxer, and there tends to be a spasming that then just throws whichever joint it is back out again. And so in Evie's case, her jaw, however many times you relocated it, would not stay in place. So she ended up with her head bound like this, and she couldn't eat, drink, smile. And yes, there was a conversation then about wiring. And thankfully, we avoided that. But jaw TMJ issues are a real problem within this population. And miserable, utterly miserable.
And as a kind of, is it not such a problem now? Have you managed to find something to help reduce the amount of times it happens? Or?
Yeah, touch everything wouldn't. It hasn't happened. Okay. That particular dislocation hasn't happened for a really long time.
Do you know why? Is it something you've been told or you've discovered?
I've just outgrown it now.
Of course. I love your candidness. Yeah, the doctor was right. She outgrew it.
She outgrew it. No, I think really what happened, and what we found with her particularly, is that you have these, it's like it decides to go for one particular joint, and then you have these repeated subluxations, dislocations. And then if you can find a way of calming, and which might be to do with bracing, taping, but also calming the muscles around, calming the nervous system, then that kind of spasming settles. And then that is where you can start to build in some strength work, physio, that sort of thing. And in Evie's case, the settling came partly because the head was bound, but also because they used some medication, and that broke that cycle. So I think you see often within and not everybody. I don't dislocate really. I subluxate a little bit, but I certainly don't dislocate. But within the dislocating population, you see these kind of cycles, and what becomes really difficult is how you manage that without ricocheting in and out of hospital. And so much is about calming the system down, which again is where we are so relevant to that care. That if you can start to calm the system, then you can start to address some of those issues.
Yeah. Really well said. And calming it down both physically through the touch and desens or dialing down the nervous system, but
Yeah.
also just listening
Yeah.
and empowering and just giving them
Yeah.
hope. And like we
Yeah.
were talking about even last week, all these episodes when we were talking about pregnancy and girdle pain, it's about listening and telling them you're not going to break, you're not unstable.
Yeah.
Something can be done. You know, you can live with
Exactly.
this. You know,
Yeah.
that's a huge thing.
Yeah.
Thank you. Right, people, what else? We've got some other comments here. Thank you very much. Deborah Slujimus says, I have a friend, 58 years, whose daughter has also been diagnosed. She is 20 years old, so inherited. It's interesting, isn't it? Because they know there is an inherited, it can be inherited. As one, in fact, that's one of the big questions, isn't it? To ask people, you know, have you got any families who have suffered from this or have any, but they still can't, the genetic testing still isn't quite on top of it for all of the types, but yeah, it's definitely worth asking that question, isn't it? Have you got anybody in the family? One thing you mentioned, I think it was when we were chatting a bit off air. Sorry, Cecily, I'll come back to your comment. Again, one of the bits of advice that I think your daughter was given was back off from the exercise, and that potentially could have been, you know, reason why some of the dislocations happen more, because those muscles which are actually more taut and kind of holding bones in place kind of relaxed, and so it's finding that Goldilocks zone, isn't it, of calming things down, but then once you can, building them up again.
And it's scary. It's scary if your body's not doing what you think it should be doing and what everybody's telling you it should be doing, and nobody quite knows how to help you. And and it's like any pain condition, isn't it? If how far do you push it? What's the payoff? How do you know whether it's good pain, bad pain? And everybody's throwing you different advice from all over the place. Who do you trust? What do you do? It's really, really very difficult.
Are you involved in the strength training side of things with your clients, or do you refer them to people who do strength training with them? Because it seems to be quite important if you're at the right stage to get range throughout that. To get strength and control throughout the range you've got, because you're going to go into that range rather than avoiding it and being scared of it. But do you work with people to help them get that strength, or?
I do bits and bobs. I'm not a strength and conditioning coach. I don't have a movement background. And so I will absolutely refer people on, which I think is the other thing as well. I think it's important to feel like massage is enough, you know, that and obviously to know to stay within your scope. So I do refer people on, and I think another thing that is a very useful thing to have in your toolkit if you're working with this community are all the online resources. You know, Bonnie has huge amount of YouTube material out there that are movement classes. There's a wonderful Mobilates network you can access. You know, there's quite a lot you can access online, and certainly some of my clients, they come and see me, and that is it for the day. You know, their movement is really very, very limited. So I suppose the end of the scale I'm at is thinking about things you can do in bed, you know, pelvic tilts in bed or bits of rocking of the knee, you know, very, very low key bits of movement that then creates a bit of momentum. And then I refer on, you know, that's where I'm at.
Good. I like the way you said that, actually. You know, don't be afraid to think this is what my job is. And just because I can't do the other stuff doesn't mean I'm not very good at my job. It's just that's not my bag. You know, that's a really healthy way of looking at it. And then just having the confidence to contact maybe strength and conditioning coaches and helping them realize, because they're not going to know all the stuff you know. You're going to know so much about these conditions. And, you know, it works from a business level, which we mustn't forget about. That's important. But also just from a satisfaction and looking after the client and getting the results. So the power of networking. Cecily, sorry, I bumped you off there, Cecily. Fortunately, they have found a great chiro who knows how to treat them, but even I've been too scared to massage them out of fear of hurting them. That's a great point, Cecily. I mean, as somebody yourself, Jessica, you've received massage, or you don't suffer the dislocation so much. Does your daughter have massages? Do you massage? Yeah. And is that from you, or has she ever been massaged by someone who's had initial fear or not quite sure how much can I do here? Or
no, because I would always vet the person before I send her.
What would you recommend to a therapist who wants to give massage and is empowered by this? What is it just communication with the client to let them know, or?
Yeah, I mean, I think you work slowly, really, and you communicate. And I think the thing that is really important is, again, thinking about it as a systemic condition. And so maybe what you're looking at is a shorter session than you would normally do. You're thinking about the surroundings. People often have heat intolerance. And like I say, there's that kind of postural orthostatic dizziness, so the turning over, things like that. But I think absolutely, establishing whether you can work together is the key. The conversation at the beginning, whether your touch is helpful to them, whether it feels like the right sort of touch. I think more than thinking about techniques and what actually am I doing, I think it's about that relationship more than anything. So I would take the focus off trying to, you're not going to fix anything. We're so far away from that in some regard that I think actually what that does is take the pressure off you, because then what you are two humans in a space seeing whether you can work together.
But what about the fear of like them turning over and suffering a dislocation of some form? Firstly, could that happen? Because I mean, Bonnie was saying how she could turn over in bed and it just
yeah. But I think,
and secondly, if it does happen, what's the scenario?
Well, I think you have that conversation beforehand, don't you? Are you likely? Do you dislocate? Do you subluxate? Do you need any bolstering? Is there anything I can do to support that? I do think the thing to be aware of, which is exactly what Bonnie says, is that feeling of wanting to work something out. Sometimes particularly the traps are super tight, and what you want to do instinctively is get in there and get it gone, but that's not going to happen. And if you work in that way, you are at risk of causing some sort of reaction. And but I don't think you should be in a position where somebody will dislocate, really. And also, people who dislocate, like Bonnie saying about rolling over in bed, tend to know what it is going to do it. It works both ways around. It is not all on you.
Good.
You ask the questions and you listen and you respond accordingly. But it's a two-way street. And people who dislocate know their own bodies. You ask the right questions and they'll tell you, and that's fine. I get the fear. I totally understand where the fear comes from. But if you ask the right questions and you listen and you work together, it won't happen. And actually, people whose limbs fall out and fall back in again will be less bothered by it than you will be. It's not something to be scared of, I don't think. Be aware of it, but you don't need to be scared of it.
Great answer. Angela Thompson's come back. Angela's been doing some research for us. Thank you, Angela. She says, looks like it's 1 in 5,000 people with a 70-30% split women to men. Oh, yeah, I saw the 70-30 bit. 1 in 5,000. Okay, so yeah. But like I say, the interesting thing is, as we started off saying at the beginning, isn't it? Separating the hypermobile and asymptomatic lot who show the range of movement, but they're not going to have any problems, from the systemic people with the right questions. But thanks, Angela. We'll try and think of another question for you to do. Come back next week. This is the 3rd week in a row. Next week's about imposter syndrome. If you want to do a little bit of research on that, thank you. Right, Deborah's come back with, my friend suffers with trigger finger. Is this something that can relate? Trigger finger. Is that a technical term which I'm not aware of?
Well, I'm glad you're not, because I'm not. No. Good. Phew.
That's fine. No, we're not sure. Deborah, can you elaborate on that? Because we are not familiar with what you're referring to. Come back to us, Deborah. Cecily's come back and says, I do have a client who has a mild version of EDS, if that's the term, who I happily treat. But this particular friend, I possibly need to man up. Thank you for the advice. There we go. I love what you said about that, the fear. And if you have, it's all about conversation. And it's not, I love the way you said, it's not all on you. Okay? Yeah. It's a two-way thing. The client is going to know what triggers it. They're not going to do something they've never done before and suddenly go, oh, pick that up, could you? They've moved around and they know their body, so it's up to you to work with them and say, is that going to be okay? Is that work? And not feel stupid.
The thing that I think I would say is that again, because of the systemic nature of it, there tends to be quite a lot of fatigue and brain fog, and some of those things it's useful to limit your treatment time for. And certainly in the first instance, if they've made a journey and they're exhausted before they get there, actually having a conversation about, my initial treatment time is an hour and a half, because they do about half an hour's consultation and then obviously the treatment, a bit of aftercare. But I might say, well, why don't we'll do the consultation on Zoom, and then you're not having to travel. Then you come and we have a slightly shorter, maybe we'll work together for half an hour. Then we'll have a little chat at the end, go away and see how you feel. And then we'll think about how we can work together. Because I've found personally, when people have treated me, and particularly if they're keen to show off lots of different things, it can really floor me afterwards. And I'm just exhausted. So I do think that that's something that's quite a useful thing to consider initially.
Great advice. Thank you. Deborah's come back saying, trigger finger, what she was suggesting is the finger gets stuck. The finger gets stuck and has to peel the finger joint. She has to in-peel the finger joint. Sounds like some kind of inflammation, swelling kind of thing. Or
yeah, I mean, certainly my fingers get stuck all the time.
Right.
Which is ideal when you're a massage therapist, obviously. But I used to, my little finger quite often gets stuck. I don't know.
And is that part of the systemic to do with the inflammation and the mast cells? And yeah,
which is the same as all my joints crack. It's revolting. But it's a similar sort of thing. They will get stuck, and then something will happen, and it will shift, and then I don't know whether it's the same thing at all.
Yeah,
but I don't know.
Yeah. Okay. There we go, Deborah. But yeah, all of this is connected to, isn't it? I mean, there's a lot of it. Bonnie was talking about the mast cells and how they're involved in the inflammatory response, and whether it's for an allergy or something, and they're overreacting, aren't they? And so that's all to do with a lot of the problems throughout the body.
Yeah.
So yeah, it could be connected to that, very much so. Right, it's 8:49. So much information there. Thank you so much for sharing all of that. We'll make sure that links go in the show notes, which listeners can direct their clients and patients, or even themselves too. But I think essentially what we've kind of talked about is, one, the great role which therapists can play in helping the initial diagnosis by listening or just sowing the seeds to somebody who comes in, doesn't even realize that their party trick they did as a kid of putting their leg behind their neck or something, or stretching their skin, is actually could be part of connected to their gastric problems they're having, or the respiratory problems, or the eczema and this and that and blah, blah, blah. And it could get worse. So we need to sort it out now. And then the other thing, helping people who have been diagnosed and providing them with somewhere safe and comforting to deal with it, which can be done. And being with them, I suppose, like anything in life, but particularly with a systemic condition, if the peaks and the troughs, the highs and the lows, it's never plain sailing, is it? It's probably exaggerated even more with a systemic problem. So being there in the good times and the bad times, I guess, is another thing therapists can do. But either way, can play a huge part. So thank you, Jessica, for sharing that.
Well, thank you very much for having me. It's been an absolute delight to reflect back on that podcast that I've listened to over and over and over again. And I think I'm sure you'll say, but Bonnie's did another one years ago, didn't she? And
yes,
that one that I listened to this morning has loads more kind of tips about exactly, so for Cecily or anybody else who's thinking about what they can do in treatment, there's a lot more in that one.
It's true. I think that was like 3 years before. It might have been episode, I'm thinking 41. 41. It was 41, wasn't it?
Yeah.
I can't quite remember all 240 of them, but I know that was 41. Yeah, no, fantastic information. And Bonnie recently finished her master's in dance science. As far as she'd finished that during the episode, hadn't she? And I'm not sure if her book's out yet. I know she was talking about a book. I don't think it's quite come out yet, but it's coming.
Coming.
The hypermobile universe, I think, isn't it? But that's on its way. I think actually, if you check out Bonnie on Instagram at Bonnie Southgate, then she's embarking on an up and coming EDS and hypermobility empower program with another therapist, and I think there's some podcasts coming out as well. So check out at Bonnie Southgate on Instagram. There's details of that. It's being filmed, I think, in the last couple of weeks. So it looks like something very exciting and useful is emerging from that. So look out for that. And for you, Jessica Yanneman, if people want to stay in contact with you, we've got the website 𝐸therapies.co.uk, and then active on Instagram. Is that a place to catch you?
Yeah. That's just 𝐸𝐬𝐧𝐧_therapies.
𝐸.therapies, nice and simple. Lovely, 𝐸.therapies. Yeah, so there we go. So people can follow you there. And obviously, if anyone's listening has been affected by this and got some questions, then you can contact me, Matt at the @STA.co.uk. Go and ask some questions on YouTube. That's probably the best platform to keep these conversations going, because they will, whenever you put a comment in YouTube, YouTube is owned by Google, so it will appear in Google as well. So you can keep the information being shared by writing comments in YouTube rather than Facebook or anywhere like that, which is just dead weight. Sorry, Facebook, but you are. Right. What will be happening next week? Here we go. So next week, Tuesday, 8 p.m. on June the 3rd. June. Suddenly it's June. My reflecting guest will be sports therapist Rebecca Stone, better known as Becky to a lot of you, of glosssportstherapy.co.uk. She's going to be taking us way, way back to episode 2 of the Sports Therapy Association podcast, to reflect on what was entitled Imposter Syndrome. We recorded that June the 2nd, 2020. God. And that was just coming out of COVID, and people going, do I have to wear this? What can I do? That was, June the 2nd, 2020, with our guest, Jack Chu, that was back then, of the Physio Matters team. So join us if you'd like. If you listen to the podcast, you want to join us for that, then Sports Therapy Association YouTube channel's best place, Tuesday at 8 o'clock on June the 3rd, to talk about imposter syndrome. Dun, dun, dun. But thank you once again, Jessica Yanneman, for joining us. I can edit that. For joining us. I really appreciate it, really honestly. And thank you, Evie, for allowing us to share your story as well. And thank you, everyone who joined us live in the comments. So Glenn Murphy, MB, has said, well, that's a must-watch episode 41. Thanks all. Thanks, Glenn. I really appreciate it. And everyone else, Cecily said, crumbs, I better start doing my homework. Yep, you better start doing your homework, Cecily. I know you're coming up as well. It's getting closer. Cecily's going to be on the show as well soon. If you are listening, you want to be on the show, then it's fine to be nervous. You're welcome to have a little Zoom chat with me or something. We can talk about it beforehand, but essentially it's just reflect. There's no right or wrong answers. It's about you talking about your own experiences and why a particular episode affected you and how it helped your practice. So it's not a quiz. No one's judging you, which is what really, as therapists, we should be doing much more of anyway, reflecting and talking to each other about stuff. So just contact me, Matt at the sta.co.uk, if you fancy coming on the show and pick an episode, and we will sort it out. In the meantime, look after each other. Add some questions to your repertoire, which you ask your patients when they come in, and hopefully see some of you 8 o'clock next week on YouTube. Until then, as always, take care of each other. Bye-bye.